I'm Michelle Forcier. We're going to talk together a little bit about contraception cases. And I'm going to do a little background, if that's okay with you guys first, and then we'll actually get into some cases. The perspective that I come from in terms of talking about contraception with teens has been informed a little bit by pediatrics, but also by family medicine. I really like the option of choice and having patients hopefully communicate to me what they need and where they're going in terms of family planning. So I look at it as not just contraception, but preparing for a healthy reproductive future for young women. And we'll mostly be talking about young women today. Some of this talk I took from a couple 3-hour workshop I did for SAM in 2010, where I really wanted to go through all the literature so that it was an evidence-based discussion, and then we could talk also about our anecdotal experiences. We're going to talk about efficacy because that's so important, what works for teens, risk, and perspective. We always give our patients this long laundry list of possible side effects and problems. And then just talking about sex with teens. I find that I learn more and more from my teens every week, every year that I work with them. And then I've got some cases. I tried to pick some cases that have multiple aspects to them that we can talk about and discuss. So again, I use the WHO and CDC medical eligibility guidelines. How many of you guys have looked them up online? Super easy to use reference. Wonderful to find out if you've got a medically complex patient. You say, can I use this method of contraception? Those are the two go-to sites. WHO has a world and international perspective. CDC has the USA perspective. And then Cochrane, American and Canadian Society for Gynecology, and then PubMed. So effectiveness equals adherence plus continuation. So whether a method works for birth control really is determined by, can a patient do it? Is it reasonable and easy enough for them to do successfully? And do they continue to do it over time? And I think this slide is just interesting in that we can see that these methods where patients have to do more, the pregnancy rate is much higher, so the efficacy is lower. And methods where the patient has to do much less, so much more effective. And looking at effectiveness and then the long-acting reversible contraceptives has changed the way I counsel teens about family planning. So if we look again at definitions of effectiveness, Trussell, Steiner, Grimes have really defined that the most effective methods with a less than 1% annual pregnancy rate are the long-acting reversible contraceptives, the LARCs, the etonogestrel implant or the Implanon, and then the intrauterine devices or systems like Mirena or Paragard. One of the reasons why they're super effective, again, is adherence. If we put them in, the patient doesn't have to do anything afterward. And then the other piece is the continuation rates. 75 to 85% for the IUD. Look at what happens with the pill, patch, and ring, which have essentially the same effectiveness and much lower continuation. So when I talk with teens, I used to start with, you can take a daily pill, you can do the weekly patch. I don't do that anymore. I start with, these are the most effective. And we'll talk about the literature behind some of these longer-acting devices in just a minute. I start with the long-acting reversibles, and then I move down through methods that are actually less effective. So it just seemed really weird to me. Why am I talking about the least effective method first? It's the most well-known method. It's the hardest to use with the most failure. That doesn't mean I have to talk about it first, and that it's changed the way I offer contraception counseling now. So let's talk about the different methods. Implanon, small, very easy to insert device, contains a progestin-only slow-release medication. It is fantastically easy to insert. There's a new device coming out called Nexplanon, like next. It's got a little radio-opaque dye, and so you can find it on X-ray if it gets inserted too deeply on radiology. And then it also has a slightly different insertion device. So that's coming up very soon. This method has about a 0% failure rate. The only failure rates in the studies were people that actually didn't insert the device. So they failed to check and make sure that the device was actually implanted in the arm. It's almost perfect in terms of failure rates. It's very easy to put in. It's Usually there's not the same issues that we had with Norplant in terms of fibrosis and removing multiple rods. And it works fairly quickly after insertion. So wonderful, wonderful method in terms of very, very effective method that lasts 3 years. And works pretty darn well. The real issue with this long-acting reversible method is the side effect profile. And again, as we talked about earlier during the panel, bleeding and weight gain are one of the most common problems and concerns for young women and women of reproductive age who are looking for contraception. When I counsel about the Implanon, we talk about irregular and unpredictable bleeding. If you sum up the if you sum up the bleeding days over, say, a 90-day cycle, there's about average of 17 bleeding days. But unlike a period where you have like maybe 5, 5, and 5, these are scattered and unpredictable in terms of when they're going to happen, the volume or the duration of the flow. And a lot of my teens don't like it for that reason. A number of teens will go on to have amenorrhea, but it's after a period sometimes of significant abnormal uterine bleeding. Weight gain doesn't seem to be a real issue with the Implanon device. And then again, there's reports of other progestin side effects, which I haven't found to be a big problem. The biggest problem I found with the Implanon is the bleeding profile. I have a number of patients who want super easy to use, super effective birth control. This is a good option for them. They have to reassure me that they understand sort of the bleeding side effects and that they're going to give it enough time to see how it goes. I have a friend who's in a clinic in North Carolina, and they took out about 90% of their Implanons. So I think pre-insertion counseling and making sure that they're really clear about the side effects is so important for this single long-acting reversible method. Again, the discontinuation rate is most often related to this sort of irregular, unpredictable bleeding, with a significant number being asked to be removed. And this is in all ages population, not just in the teen population, 6 to 12 months out. And again, we know that whatever method of contraception we're using, that pre-insertion counseling, pre-start counseling is so important in terms of having patients know what to expect in terms of early side effects and then potential long-term later side effects. Another long-acting reversible device that I start counseling with again immediately are the intrauterine devices. And there's the copper T, which lasts 10 years. It also, we know it lasts up to 12 years, although it's not FDA approved for that. And we actually have some evidence that it could be useful as up to 20 years. The issue with the copper T device is very effective, but it causes heavier, crampier periods. So again, for a lot of my younger patients, that's sort of not an ideal modality. The levonorgestrel IUD is known, FDA approved up to 5 years. We know it works at least up to 7 years. And it has a very nice bleeding side effect profile that we'll talk about in a minute. So those are the two United States approved, FDA approved intrauterine devices. They are spermicidal and oocidal. So for patients who are concerned about their personal definition is pregnancy and conception is at the moment a sperm, egg, and fertilization, versus our definition of pregnancy is implantation into the uterus. This is not an abortifacient, which may be important for some patients to know in terms of choosing a method of contraception that feels religiously or ethically correct to them. So why aren't we using? Why don't the 50% of teens who are sexually active in high school have IUDs? Well, there's been a lot of myths that have sort of continued from the 60s and the Dalcon Shield. We used to say that if you had a history of PID, IUDs were not a device for you. If you had more than one partner, we used to make people get pap smears and STI testing before. There were always concerns about how would this impact on fertility. We have over 20 years experience now with the current devices where we know these are all myths and not true or accurate reasons to deny young women some of the best methods of contraception. We know that we can use it in nulliparous patients. I offer it to a number of my teen patients. I offer it in the outpatient setting with a paracervical block. I offer it with a little bit of Valium and a chaperone to get them home. And I also offer it with conscious sedation, finding that a number of women, this is their first pelvic exam. and it's scary, and the speculum itself is really the difficult part for them. So we give them a little Versed and fentanyl and can insert it fairly easy with some conscious sedation. It works very well in the nulliparous as well as the Paris patient. There may be a slightly increased risk for expulsion with a smaller, never-been pregnant uterus, but it's, again, a fine option for our young and never-been pregnant patients. The big issue that people got or get really concerned about with the IUD is that IUDs cause STIs and PIDs, and I think we really need to be clear that infections are related to STI exposure, not the device, and there's really good evidence on that as well. Also, for the Mirena IUD or the levonorgestrel IUD, we know that progestin thickens the cervical mucus, which offers some protective effect against PID. They've sorted out the data. And the PID risk related to IUDs is related to IUD insertion through an infected cervix. And so that we can see that the baseline risk of the population is the same as the risk for PID in women shortly after the insertion rate. So if we insert an IUD through an infected cervix, yes, the risk of PID goes up. But over time, again, that risk goes down. And so what they've found is that in all populations, prophylaxis doesn't offer us much. But if we're talking about adolescents, where the rates of chlamydia and GC are so high, we know that actually either testing for or treating for PID, GC or chlamydia actually can have some benefit in decreasing sort of the ascending infection or the sequelae of putting an IUD through an infected cervix. So I test everyone for GC and chlamydia, ideally before I put an IUD, or I test them at least at the time of the insertion, and then we can make sure that we get back to them if we do need to treat for GC or chlamydia. We now know that we can leave IUDs in if you're diagnosed with chlamydia, GC, by screening exam, if you have cervicitis, or if you even have pelvic inflammatory disease, upper tract disease. So you leave it in, you treat around it, and you only remove it if your patient continues to be unresponsive to both oral or IV medications. And I have all sort of the references for folks who want to, who themselves like to look at the data behind the recommendations. So the teen IUD literature is incredibly sparse and could use some really good studies from our colleagues interested in reproductive health. The couple of studies that I pulled up that are out there that might be helpful, there's one study that talks about 40% of 14 to 24-year-old women have heard of IUDs, and so that's less than half of young women have heard of IUDs, and their positive regard for the IUD increased significantly, statistically, after 3 minutes of education. So we need to get the word out that this is one of the methods young women can use for contraception. The randomized clinical trial is a small study, but it was done by Godfrey in Chicago, and they randomized Paragard and Mirena, and basically the continuation rates were fairly the same as their adult colleagues, with the Mirena IUD having about a 75% continuation rate at 6 months, and the Paragard slightly less, again because of the heavier, crampier periods. There's two recent studies that just came up in October that talked about really no difference between nulliparous or Paris women, adolescents versus older women, for expulsion rates, or for the likelihood and reasons for removal. Dissatisfaction with the method, oftentimes due to irregularity of the menses, was the reason for removal in about 10%. And then again, that was fairly similar for teens as well as older adults. And then versus a desire to become pregnant as a reason for removal was about around 2% for both teens and older women. There's a second study that again looked at difficulty of insertion. These are things that could be barriers to providers wanting to offer this device. And basically 80% in this study of teens had no difficulty insertion. If they did have difficulty, it was more likely to be in the teenage group, which again is as you'd expect, and they did have a higher incidence of using dilators to open the cervix for IUD insertion, again in the nulliparous group. Again, the expulsion rates and the continuation rates were fairly same as their adult counterparts. So again, remembering what probably the two most important articles about adolescents and IUDs are the ACOG committee opinion from 2007. it's almost 5 years ago, that said IUDs, long-acting reversibles, should be a first-line option for teens. And then the Margie Gold's Current Opinion in Obstetrics 2008 article, which again reviewed all the literature about adolescents and IUDs. So I offer long-acting reversibles, including the IUDs, as my first line of birth control. And I really like Mirena for the side effect profile of 50% within 1 year have no periods, 80% within 2 years have no periods. There's overall, if you add up everybody, a 90% reduction in blood loss for menses. So menses for everybody, whether you have them or don't end up having them, are shorter, lighter, and easier. And again, that's after the first 3 months where everything might be a little bit wonky in terms of cramping and bleeding, whether you're on the pill, the patch, or the IUD. So we'll do a couple quick updates for the old familiars. Condoms, I really like to separate condoms out as condoms are great for STI protection, contraception for birth control and family planning, and partner selection for who you're engaging in sex with, and then again making sure you're satisfied with your relationship both physically and emotionally, and that this is where you need to be. And so I like to take that sort of multi-look around the desires to have safer, healthier sex. Condom rates are fairly high. I use the numbers. If there are 5 of us girls in a room and we're all really good at using condoms, 1 of us in a year is likely to become pregnant. Again, knowing how teens use condoms. And again, it's the most common method of use, which is, again, great for STI protection, but it's often inconsistent or incorrect use, so it's not our best method for birth control. All my non-long-acting reversible contraception users leave with prescriptions for Plan B, because again, we know about adherence and we know about continuation, and I just like to make those connections explicit for my patients. Again, OCP failure rates can be as high as 25%, again related to adherence and continuation. And a lot of teens don't know if you're off your methods, any of these hormonal methods, for more than 7 days, there's a risk for ovulation after that. So again, having them just be aware of how skipping pills or not starting their next pack on time may affect their fertility or their protection. The ring, I think it's important to know for our self-pay patients who really like this device, you can leave it in for 4 weeks, has 4 weeks of medication or effectiveness, and then they can either extended cycle or take it out for a period week 5. Just again, could extend the life of their method, especially if they're paying out of pocket.
I'm sorry, so they can keep it in for 4 weeks?
4 weeks.
Take it out the 5th and then do the next one?
Yep, 4 weeks, yep. So you can use it for a little bit longer period. And again, you can extended cycle with the pill and the NuvaRing in terms of having people that don't want to have a period necessarily every month. The patch, again, a very useful method. It has slightly more estrogen in the bloodstream, and we'll talk a little bit about what that might or might not mean. What it does mean in practical terms is that we don't. It's not standard to extended cycle with the patch, and that's something that most providers that I've queried are not comfortable with doing, just because we don't exactly know what that higher area under the curve of estrogen in terms of estrogen content in the body means for these women. And then in Depo, we've been able to clarify we have no need for a pregnancy test if they're late for their injection under the 14 and 0 week period. And again, if teens discontinue Depo because of weight, they're very unlikely to start it, even if weight and Depo have very little to do in terms of the real reason for their weight gain. So just things to know as we counsel patients forward. A couple other really important points. Quick start at contraception has been another effort to improve contraceptive starts and efficacy over time. We can start almost any method of contraception on the day of the visit, except the IUDs. We don't want to put an IUD in a pregnant uterus. But we can start, and we don't have to wait for the first day, you know, the first 5 days of their next menstrual period. We don't have to delay. They can start pills, the patch, the Depo. However, if they have not, if they've had pregnancy, unprotected sex 5 days or fewer, we want to think about offering emergency contraception that day, get them started on their birth control method that day or the day after, and then have them come back and do a pregnancy test in about 2 or 3 weeks to make sure that we didn't either miss an early pregnancy or have an early pregnancy at the start of their method of choice. If someone has unprotected sex between 5 and say 10 or 14 days, their pregnancy test is inconclusive. We don't know if we're missing a very early pregnancy. You can still start them on most forms of birth control at that visit, again with the caveat that you're going to want to do a pregnancy test 2 to 3 weeks out from it to make sure that we didn't miss an early pregnancy either before the birth control started or at the very beginning of the birth control start. And then if the pregnancy test is negative 10 to 14 days out, we can start them with any method of birth control that day, not having to wait for a period, including now the IUDs, with the caveat that other than the Implanon and the Paragard IUD, they need to wait 7 days and have protection for the next 7 days until their method really kicks in. Okay? We know that the Paragard kicks in right away and that the Implanon kicks in within about 8 hours. So I always think of how can I get these patients started, how can I get the barriers and delays out of their way. Last but not least is emergency contraception. All my non-long-acting reversible contraception patients get emergency contraception. We're not doing the best job in terms of talking about the different forms of emergency contraception or explaining how to use it. So that's a part of every contraceptive spiel is about emergency contraception. Even if they have a method they like and use, we know that teens will come off and on various forms of birth control through their reproductive life cycle, and this is important information for them to know. Pediatricians with adolescent patients, a number are prescribing or counseling about EC, but we can improve those numbers. And it's really interesting. There's a study about emergency room docs with EC, and they surveyed a number of the pediatric ER medical directors, and they're all offering EC with rape, status post-assault or rape. What they found is that none of them were offering EC for young women that as a part of their evaluation, belly pain, nausea, fatigue, that there was a contraception concern. So again, we can do it not just in the context of rape, but just in the context of general contraception. Again, new article out in terms of recent updates. A recent article, I think it was in October or November, that looked at Plan B, and that it clarified that, again, Plan B prevents sperm and egg coming together, but is slightly less effective in this study, in terms of 68% effectiveness, when taken in the middle of that most fertile part of their menstrual cycle. So Plan B has its pros and cons. It has not been shown in population studies to decrease rates of pregnancy when it's been offered to teens and young adults with early access. So if you give a patient a prescription for Plan B, we don't know that it's changing the rates of unintended pregnancy, and we think that some of that maybe patients use Plan B inconsistently, and we're not exactly sure why they might use it for this episode of unprotected sex but not for 2 others afterward. So it's not having the population effect we really thought it might. Ulipristal, or Ella, is now out. That's a mifepristone-like method. It also blocks or stops ovulation. There's some question that it may be, and again, early studies, more effective later out. We know that Plan B gets less effective the further out from time 0. Ulipristal may be as effective, though, 72 to 120 hours out. Again, more to come. There's a suggestion of that. And then I think something that we all forget, I don't have very many takers for the copper IUD in my clinic, but I keep one of these in my clinic because this is actually the one single emergency contraception that is 100% effective. Copper IUDs placed in those first 5 days, very, very effective emergency contraception. And for a number of women, and those are not teens, many of them retained the copper IUD for long-term birth control after. So I think it's just something to think of and something to have available for your patients. So risks and benefits in perspective. When we counsel about birth control, especially I think from a pediatric perspective, at least how I was trained, we talked about this horrible thing with blood clots and strokes and heart attacks. I'm going to give you a couple visual tools to hopefully help you reconfigure the sense of risk, the perspective of risk with these methods with your patients. So a lot of the slides coming up are going to say the same thing. They say it in different ways because I think different people have different styles of presenting this information. If we look with a Paling diagram about risk and perspective, there are risks that are 1 in 1 trillion, very, very rare, and then risks that are common, say 1 in 10, 1 in 100. And there's a sort of increasing logarithmic scale of risk. If we place the true risk of, say, death from an estrogen-progestin method of contraception. The numbers are less than about 1 in 1.5 million. You're more likely to drown in your bathtub. I have yet to not tell my patients to do not bathe because you may drown, or annual risk from death from accidents in the home. Again, the risk of a VTE, which is more common than risk of death, 1.5 in 10,000. Still much less risky than VTE or risk of death in someone undergoing childbearing and pregnancy and delivery. So if we look at sort of the true value of these risks, we can, I think, counsel about these methods and the estrogen and the VTE risk, which is usually people's biggest concern with these methods, I think a little bit more fairly with our patients. Another way to look at this is risk of death. I'll tell patients that it's close to being as likely being struck by lightning as you dying from your birth control method as a healthy, young, non-smoking women. These risks become quite real as age and tobacco start to interact with estrogen. So it's not an unreal risk, but in our population, the risk is usually very low. And I'll often say it's much more dangerous to ride your bicycle or to come to clinic to see me than to use these methods. Again, it doesn't mean the risk isn't there. I saw a young woman in clinic who has factor V Leiden and another prothrombotic disease who they discovered her disease 3 months after starting oral contraceptives for irregular periods, and she had a basal ganglia stroke. So those risks are real, but statistically over our population, especially in otherwise healthy young women, they are fairly rare. Another way just to associate risk, and oftentimes this is the conversation that's important to parents. Our population, we're so lucky, our population is those who are the lowest of risks for a venous thromboembolic event. Very, very low. And then again, if we look at these numbers, again, what is 1 in 10,000 or 10 in 100,000? A very small proportion of the overall risk. So I put these slides up mostly to just get people to think about how do you want to communicate. This is one of the ways I like the best because it's easy numbers to manipulate. The risk of a VTE 10 in 100,000 increases by 50% with second-generation progestin OCs. Third-generation progestin oral contraceptive pills, the Ortho-Ever patch with its 60% increase over the curve, or Yasmin, the drospirinones, that doubles from 15 to 30, but they're still really low absolute risk numbers. And we certainly don't look at women who are pregnant and say, oh my gosh, you're pregnant, you're probably going to die. So putting those risks into perspective for patients and parents is so important, because if we start counseling about these terrible effects of this medicine, we want you to go home and use it, that's probably going to interfere with adherence and continuation if they're afraid of the method that they've chosen. So I want to know if you guys want to talk about specific pieces about counseling about contraception and sort of some female reproductive health stuff, or do you want to go right to the cases? What works for you guys? I've got some counseling tips next, and then we can do cases, or I can go right to cases.
How about the counseling tips?
Counseling tips? Okay, we can go through that fairly quickly, and then we'll go to some cases.
Can I ask a question?
Yeah.
The first one is, have you seen, and this might just be anecdotal from what I've seen, and I haven't seen that much of it, but people getting pregnant on the NuvaRing?
The failure rates for the pill, the patch, and the ring, even though the adherence issues theoretically might be easier, the less you have to do on a daily, weekly, whatever basis, the failure rates are the same. I estimate the failure rates when I'm talking with patients about, say for all comer populations, say 16 to 45, the failure rates for pill, patch, and the ring are about 9%. I up that estimate knowing that teens have greater issues with continuation and failure rates to say 15 to 20 to 25, which is what we know for the OCP. But the pill, the patch, and the ring essentially have the same failure rates.
And then my other question is, so it sounds like the IUD is really safe for teens. There's really, is there any contraindication?
If you're pregnant?
Yeah, if you're pregnant.
You wouldn't want to put a copper IUD in someone with Wilson's disease.
Right.
You would, if someone had severe uterine abnormalities, you might not want to put an IUD in. But for most young patients, there's very few. I mean, we don't really have the risk of endometrial cancer. We actually know that it's FDA approved. The progestin-only IUD is FDA approved for menstrual irregularities, and our peers are using it for menstrual irregularities and heavy irregular bleeding for older women instead of taking out their uteruses, because it's a much less invasive procedure. So I use that method for menstrual problems. I use it in my developmentally delayed population, who they want good contraception and that sort of protection, as well as for causes of reasons of menstrual hygiene and maybe period issues. So I think there's so many different methods. What we know is that long-acting reversibles, they work because patients don't have to do much, and they can keep them for a while, and that's what makes a difference in terms of effectiveness. The other thing I tell patients in terms of connecting with them is this is the method that all the OB-GYN residents are running around the hospital with. This is what women in that field are doing for themselves. So again, I want to offer them first-line best methods of contraception. And I start with that first when I counsel.
What's the return to fertility? Because I think sometimes people ask that question, even teenagers, if they're just wondering, and they're like, well, I heard it's hard to, if I want to get pregnant afterwards, it's hard to.
Yeah.
And I don't remember what the...
Immediate. Yes, I have a colleague who had her Mirena in for her trip to Italy as she finished fellowship, and she took it out and got pregnant the month after. So both anecdotally and the evidence, the return of fertility with especially the IUDs is very, very rapid. A little bit longer maybe for Implanon, but not much. And then Depo is probably the one via its slow release mechanism that has the longest return to fertility. So, but yeah, pretty rapid. And again, not affecting future fertility in any way. Chlamydia is much more likely to affect your future fertility than is an IUD. So I think we talked a little bit about this in the morning, but I think the big thing about offering women contraception is I think to try to make this normalized. Sex isn't just about bad, scary risk disease. You're supposed to be sexual as a person, as a human being. And what we want is for people to be educated, informed, and be thoughtful about their sexual development and their sexual initiation, their sexual behaviors. So I think talking about it early on in a developmentally appropriate way is just so important. And it's so much easier, I find, to talk about it before it's an issue. We talk about it when it's hypothetical. The big thing I use is, oh, when your daughter, who is always going to be your perfect princess, has sex when she's 30, 35, and everybody laughs because they know that's unrealistic. But it addresses that dynamic of no one wants to think of their 12, 13, even 16-year-old perfect princess having sex. But we need to talk about it, and we need to have a plan for her to have knowledge and access to resources to do this safely, if and when she decides to. Asking patients very direct, specific questions, and being aware of the language we use as we ask those questions to make sure that we're really opening the door for people to talk about their sexuality. Again, using correct terms, talking about things that are upcoming that they might expect, normalizing. These are not uncommon things that many, many other young women are going through. And again, safety and decision making. And getting parental buy-in. The privacy part of our sexuality visits is not so much that we're keeping secrets, but it's young people need to have a safe, private place to ask any and all questions. And our goals as providers, as well as your goal as a parent, is one and the same. It's the health, the safety, and success of your son or daughter. And I think making that explicit to parents gets you so much buy-in as you talk about these things. It also buys you some relief. Parents don't want to necessarily talk about the nitty-gritty details with their kids. We can provide that place, that safe place for parents to know that we're going to also advise for the best health of their teen. And I think, again, we talked about clarifying what patients want shared. At the end of the visit, mom's out in the waiting room. A lot of times she'll come back. The teen is like, what is she going to say about our visit? We clarify explicitly. We're going to talk with your mom about X, Y, and Z, but we're not going to talk about your oral sex or this or that. We'll talk about these specifics of the visit, but not possibly every element of the visit, so that a teen can listen and participate in the conversation as opposed to being worried about what I'm going to let slip about her life. And again, not you know, sometimes at these conferences, you guys are, it's like preaching to the choir. You guys are here. You guys are savvy. You guys are already doing this. You know, you guys know all this already and are doing it. It's almost maybe more appropriate for folks who really have a hard time with this topic, who don't want to think about it. Those are the people in some ways that we really need to reach out to. Not so much in terms of you have to do this, but knowing that you guys are appropriate referral sources if other providers, because of values or their personal ability or comfort, can't do this kind of conversation work. Young people need to be referred. And that's where we can interact with our subspecialty friends or other pediatricians who may be less comfortable with this topic. And they really seem to be very appreciative of this service that we can offer. So again, developmental approach to sexuality. You know, kids know their gender identity like to age 2 or 3. So we talk about girl parts and boy parts, talking about what the different parts do. In the sort of latency age, school age, this is a good time to really tap into this rule-based social responsibility, values and morals, and we can use these opportunities to talk about sex and bodies and relationship to get this conversation comfortable, and so that our kids know that they can talk with us when they have questions, as opposed to maybe talking with, you know, Joey down the street who says, well, you know, your hands will get hairy and you'll die or go blind. Sometimes those myths are really still out there. As we get into the tween, I think we really miss opportunities to talk to young women and young boys about sexuality and prepare parents for that discussion about sexuality with this sort of let's get ready for puberty. And so we take it developmentally about the bodily changes, the social changes, the cognitive emotional changes, and that can lead into discussions about how they see their maturing body, gender identity, sexual orientation, and just open the door to the many ways that young people will explore and express their sexuality. Again, for the 12 to 18, where they're supposed to be experimenting, they're supposed to be exploring, and they're supposed to become sexually interested possibly, is talking about it in an empowerment health promotion model where, again, sexuality is a healthy part of our development, but we want you to do it safe, smart, and with considerable deliberation. And again, how it's related to relationships and how people are growing in their community or their intimate romances. So these are the specifics of a detailed sexual history that I will try to get at as sort of broad global concepts. I'm seeing a fair amount of patients with gender identity concerns, and at first it seemed really uncomfortable for me to ask, do you identify as male, female, or somewhere in between? And now it's just this thing of practice where it makes total sense. And some patients look at me with kind of like, what? And other patients look at me like, oh, well, of course. And they talk about being somewhere in between. And I think gender identity is something that pediatricians and people who work with kids need to be very attuned to, because we can have a very big difference in outcome if we're dealing with transgender health pre-pubertally and early in their development of gender and sexuality. Again, sexual orientation is different than sexual behaviors. There are many, many men who have sex with men who identify as straight. They don't identify as gay. So separating out orientation, attraction versus specific behaviors and what parts go where, I think is really important and really clarifying your sexual history. I often will, for the early teens, talk about calling on the telephone, crushes, hand-holding. Those are initial forays into sexual exploration, and those are very important and meaningful parts of young people's existence. And so we can use that as a way to sort of talk about things developmentally over time. Number and genders of partners, again, separating out condom use and birth control. And again, not making the assumption that everybody wants to contracept. I have two learning lessons that I went through when I was getting started. One was a great, brilliant contraception lecture for one of my patients who was gay. She's, you know, she's like, whatever. And then the second one was for someone who doesn't want to contracept. So I think it's just so important to ask, what are their family planning sort of immediate needs and long-term goals before we assume that the 13, 15, 17, 20-year-old wants birth control as we talk about this. Sexual satisfaction. The more I ask about sexual satisfaction with young women, the more I find it's not that great. And I think talking to young women that, you know, sex can be really quite lovely, let's talk about maybe how to make that so for you. And if they're ready for that, having those conversations, knowing some of the resources to talk about sex as being a beautiful and intimate part of a relationship, not just something that we have to screen for risk and cancer the way we normally frame sexuality for young people. So cases. How many of you guys have seen this patient? How many times, should I say, how many times have you seen this patient? So a 15-year-old teen, BMI of 35, Seroquel, Abilify, Depakote. She comes in for pregnancy testing, and you have had, you know you've done the contraception talk for her at least 3, 4, 5 times, and was on Depo and said, I am never going back on that. It made me fat. What are some of the issues? I put a couple embedded a couple issues in each case that we can talk about.
I'm sort of thinking about like that she's on those antipsychotics, which caused her metabolic disturbance. It probably made her gain the weight initially, but if she has any problem with Depo, she could get an IUD.
Yeah. Well, I think the first is addressing her concern, like what are her barriers to contraception? And she has a couple barriers in the sense that she's young. She does have a BMI of 35 with her concerns of being heavy. She's on some medicines that have weight gain also associated with them. And weight is like the most common cause for women to really have fears or concerns about birth control before they start. That's one of the biggest causes and concerns. So we know that perceived weight gain, not always real, but perceived weight gain or perceived weight gain due to method as opposed to due to other lifestyle. And so I really try to talk about lifestyle a fair amount in terms of saying Depo is not going to all of a sudden make you go like this. Depo can stimulate your appetite, and if you're already having a hard time controlling your appetite, yeah, then that may be a real problem for you. So let's talk about something else, because we know none of the other methods really have that same appetite and weight gain effect or profile. At the Adolescent 2009 article, very nice review of much of the evidence behind some of these. So it's a good article to look at. And again, for Depo, if you're underweight or normal weight, really no impact on weight. So if you have a skinny little teen who says, I want to go in Depo and get some curves, it's probably not going to work. It's really young, already struggling with weight teens. I think the literature about ambivalence is really interesting. Again, sometimes why people are in for repeat pregnancy tests or why they're not contracepting effectively is because they don't want to. And there's some interesting studies with teens having ambivalence just in general about being sexually active. Not sure that it's really what they want to do, but they are, about using contraception and having to sneak around to use it, about wanting or avoiding pregnancy. There's some great studies that say, many teens say, if I got pregnant, that'd be okay. That's, pretty ambivalent as you get to look at sort of their true desire or need for contraception versus it would be okay or maybe even really good if I got pregnant. And so we need to figure that out before we offer them, before we decide what to offer them in terms of the family planning menu. Method side effects, difficulty with use and continuing the methods, and then there's some studies that say that they're not really satisfied with the way their providers talk to them about their birth control methods, and they don't necessarily feel like they're being heard or that they understand what the providers are really offering. And then there's a variety of other factors associated with risky, i.e. contraceptive behavior, not necessarily using contraceptives consistently or correctly. Again, lack of partner support. Being pregnant and being a parent may be their one route to having status in a place in their community. Socioeconomic status, a lot of times infrequent intercourse. Well, I'm not really having sex all that much, so I don't really want to be on something every day. Or not being in a current relationship. We know that teens have serial monogamies. So, you'll see a teen, are you sexually active? No. When was the last time you were sexually active? About a week ago. It's like, okay. no, you're not sexually active now, but. So their sense of time is different than ours. And so being very specific about how relationships maybe quickly move, and most teens don't get into a relationship and say, well, I'm going to have sex in 2 weeks from now, so I better get on my birth control. And talking with them about realistic planning for new relationships and initiating a new sexual relationship. So I often will try to ask patients what they want in terms of family planning. Is it birth control? Because it may not be. And if they want to start a family, why? Especially if there seems to be some issues that may be obstacles for that teen being successful for herself as well as for her family in an early parenting situation. So we'll talk a little bit about why and what does this teen desire with a pregnancy. We talked about this a little bit earlier with the panel. She's got some medication issues. That's a part of where thinking, rather than just pregnancy prevention, thinking about sort of preconceptual or family planning, we need to address some of these pregnancy medication interactions so that we can advise her properly about what comes next. And I really recommend, according to the ACOG guidelines, we know that 50% of pregnancies are unintended. So that pretty much every menstruating female probably should be on prenatal vitamins. Because we just know that, again, about half of pregnancies aren't planned, whether you're young or old. And so we know folic acid works better before you're pregnant. And that's ACOG's recommendation for a long time. And I try to use that also for folks who don't want, they say, I'm not going to use birth control, I don't want to use a condom, and I don't want to be pregnant. Well, I'll say that's crazy thinking. Because that's not very realistic. So let's talk about a realistic plan for, if you're going to do that, let's plan for a safe and healthy pregnancy. If they're just having trouble with their own ambivalence about intending a pregnancy, and say, well, even if you don't intend a pregnancy, the right thing to do is to be on these protective prenatal vitamins to get you in the best health possible should you become pregnant. So I'm very proactive about prenatal vitamins, again, as a way to make it real. And so that there's not, oh, I can't believe this happened to me. Well, you had 2 years of unprotected sex.
Are there any negative side effects to the prenatal vitamins?
Constipation? No, constipation is a side effect from, the iron in them. They're big horse pills, so a lot of teens don't like to take them. And they're a pill, which, again, teens that are hard to do every day anyways. But it's one of those things where I'm like, if you're really thinking about starting a family, this is such a small thing to do for the health for yourself and a future child. This is a good way to see, are you really ready and committed to starting on this path to parenting, which is way more than just being pregnant. It's about putting your child's needs first in addition to making sure you continue to be a healthy person and grow up into a healthy adult. And just really, again, trying to have them conceive of this as a responsibility and active, it's an ongoing active role that they're going to have in terms of making decisions for their health and the health of a child. So again, just trying to make it as real as possible in terms of the outcomes of unprotected sex. So I have a couple of these charts where I put together a variety of different meds with either teratogenicity or interactions with birth control. And I think there's the variety of pregnancy risks. And we know that some of the atypical antipsychotics we don't know a ton about. Abilify and Seroquel are on the category C. We know that the benzos are very much not recommended during pregnancy. We know that Depakote as a mood stabilizer is a category D as well. So I have this chart in my clinic just because I have so many patients on a variety of different mental health medications that I like to check when I'm looking at birth control along with their other mental health medications. And again, there's a lot we don't know. This is what I could glean from the literature in terms of what do we know, because it's not necessarily appropriate to discontinue medications depending on the psychiatric concerns for the patient. And that's where a conversation with the psychiatrist, conversation with the patient, and maybe delaying pregnancy for a little while with contraception so that we could figure out the risk-benefit sort of profile for maintaining their mental health status along with optimizing their sort of preconceptual health status and decreasing risk of teratogenic effects. But we know that Depakote does have a dose response, and this can be related to neural tube and other physical face and limb defects. Carbamazepine and Tegretol can be related to some facial dysmorphism and nail hypoplasia. Paxilloperoxetine has some craniofacial and heart defects. Again, the numbers aren't huge. They're just there, and they're things that we need to be aware of. In the third trimester, we often want to just be really aware of SSRIs as well as lithium, and we don't really have a whole lot of evidence regarding the atypical antipsychotics. So I think just, again, things to know as you're screening folks for, are they using contraception, what are their other medications, what are the risk benefits of possible pregnancy versus preventing a possible pregnancy. 16-year-old with irregular, heavy, painful periods, acne, and mood changes. You never see this. Never in your clinic. And of course, in confidence, she reports, I'm having sex and I don't want you to tell my mom. What do you guys think? What are some of the issues here?
Well, it sounds like she would probably be a good candidate for an IUD, but like if she doesn't want her mom to, I think that it's kind of difficult to figure that out. So.
Yeah. Well, it's also hard because the IUD isn't necessarily, if it's all local oocytal and spermicidal, isn't necessarily going to suppress that HPO axis for her, for which she could get some benefit if she wasn't sort of regularly monthly secreting estrogen, progesterone, and maybe having higher testosterone levels than we would like.
That's also a way possibly to get her on some of those pieces. You can talk to the mothers. You know, this may help with her periods and DVDs, so you get double benefit.
Yep, yep.
The mother's probably going to make sure she takes the pill every
Yep.
day. So.
Oftentimes I'll talk about the side effect of contraception or birth control, which may in fact be some of the main effect we're acting for. But I'll directly say these are the same methods that we use for birth control. So yeah, and there's a sort of a double, possibly a double benefit. So, you know, I think the 16-year-old and the age piece for me is really, when I first came to Rhode Island, having come from Illinois, it was important for me to figure out what are the local laws. What's my clinic policy? How do they handle things? How does the institution that I work for handle things, including medical records and release of information, as well as what's our state law? And then how does this fit into sort of some of our U.S. statutes? And in Rhode Island, minors can get STI testing and treatment, as well as some substance abuse and substance abuse outpatient treatment. But there really are no specific laws for pregnancy testing and contraception counseling. In the 16 to 18-year-old age group, we often use this routine. They're allowed to consent for care for routine urgent care, for which most of us interpret as definitely pregnancy testing and contraception. So again, knowing your local and state laws can help you figure out just sort of what your practice parameters are. For Massachusetts, you guys actually have specific in your privacy and consent, like we did in Illinois, family planning services and some mental health, outpatient mental health treatment in addition to substance use. Services that are not private or confidential are abortion, which either requires parental consent from at least one parent, but not necessarily both, or a judicial bypass. And then safety. So anytime a patient might be at risk of hurting themselves or being hurt, we want to know. And we can't keep that secret. And I usually run over these things quite quickly in the first 2 minutes. It's a 1 to 2 minute spiel with new patients about sort of the rules of the road for this clinic in terms of confidentiality. And again, I think in practical terms, thinking about how your institution handles medical records is really important in terms of when patients have the right to consent for care, they have the right to consent to release their records. However, if they don't have that right, then parents do have access to records. And different institutions handle medical records very, very differently. And so I think really seeing where the parent stands and the communication of the patient and the parent is so important. And letting the patient know really what is truly 100% protected, what is mostly protected but not 100% guaranteed is very, very critical, especially for some of the patients where safety in terms of maybe a pregnancy or a sexual orientation issue may put them truly at physical risk if someone were to find out that they didn't feel safe with. And this is exactly what you brought up with the menstrual problems in teens. Again, when I talk with teens about their menstrual history, it's a great lead-in before the contraception talk, so that the provider, the mother knows or the father knows you're always going to talk about their periods and all this sort of sex stuff because it's a part of puberty, and even if they're not sexually active, you're going to be bringing these things up. I want to have them define what irregular means, what heavy means, what a migraine means. I want them to define what mood changes means. I want more specifics. Rather, because normal is on a curve for many, many patients. And I want to think about, do I need to screen for anemia, bleeding disorder, other sources for the abnormal uterine bleeding, or hyperandrogenism, and how worried am I about how high that testosterone might be? I might consider NSAIDs as treatment if there's no platelet concerns. Again, and the variety of hormones we can use that have benefit in terms of either making periods lighter, shorter, more predictable, or causing amenorrhea in general. So she's got some options, both in terms of her periods as well as with her contraception. And again, this menstrual history is just, I think, a really nice, easy way to ease teens and families into this about what to expect when they come to your clinic. Estrogen progestin methods have their pros and cons like anything else. The pros, estrogen provides great lining regulation and regulation of bleeding. It shuts down the HPO axis in terms of all the syndrome of hyperandrogenism, acne, hirsutism, the irregular menses. We can extended cycling of methods so that they don't have to have a period, and these drops in hormones may be related to their mood changes with their menses. And then there's some question about 24 and 4 pills where there's a shorter period of no hormones that might have some benefit. That's not been proven. The only thing that's been proven really with the 24/4 hormones is that they're as effective as other methods. The cons, again, if you're using pills, as you brought up, for contraception, they're not going to be as effective as other methods. And that, again, they're easy to forget. And if you forget your pills, that's a very common reason for having abnormal uterine bleeding. So it's inconsistent hormones is a good reason for AUB. Again, this is some of the data we already talked about with the levonorgestrel IUD. Again, think of it too with some of your, some of our developmentally delayed patients in terms of being able to offer them also hygiene and menstrual suppression, again, for parents who are caring for these kids for many years. And there's some evidence there may be some benefit for young women who have endometriosis. So we know that the levonorgestrel IUD is also very helpful for young women who have bleeding disorders. So it's a very useful method if you are going to be worried about other hematologic problems that may increase a patient's risk of bleeding. And then again, we can use medroxyprogesterone, either oral, IM, for young women who have estrogen contraindications, i.e. if she truly has migraine with aura and neurovascular changes. We can use progestin-only methods to suppress the HPO axis. We can use it to decrease periods and perhaps induce amenorrhea. It's less predictable than the estrogen progestin methods in terms of how soon it works and its effect on the uterine lining. A 12-year-old teen with developmental delay, seizures on carbamazepine, lamotrigine, and a history of aspiration pneumonias. And she's in there with you and her mom for her annual physical exam. What are some of the issues related to her reproductive health that you guys could offer her some help?
I think it's still important to ask about her relationships, and because even though she's delayed, she's still likely.
Yeah. Yeah. Remembering to offer our developmentally delayed patients, whether it's physically or mentally, cognitively, to offer them the same preventive anticipatory guidance, again, scaled to where they are, but offering those same elements of anticipatory guidance and development that other teens are going to be going through. I think it's real interesting that there's some great studies that really link, if you have other medical problems, including neurologic problems, whether it's seizures, developmental delay, you're more likely to have irregular periods. That makes sense because it's, the brain and the HPO axis, the hypothalamus, the pituitary, all is communicating with the ovaries and the uterus. So we often forget, again, that not only do these women need sort of the regular puberty's coming, well, how are you going to handle this, mom and or daughter, but they're more likely to have problems with their menses and their HPO axis. We know that folks with epilepsy can have pregnancy fertility, PCOS, and again, other hypothalamic issues. So I think good menstrual history, good menstrual screening, especially if there's any possibility of a neurologic condition, is very important. The other thing that really speaks to me is I have a lot of moms where their teens are developmentally delayed, and I see them at 18 or 19, and I talk about extended cycling or amenorrhea as a side effect, and they're like, why didn't anybody tell me this before? So she's been having periods since age 10. It's been 8 years of difficult periods because of behavior, because of hygiene, and mom and she has had to suffer with them. So again, that menstrual history for the developmentally delayed patient, I think, is even that much more important. I think, like you said, not assuming that developmentally delayed patients aren't going to go through some elements of their own sexuality. Masturbation is normal. And again, it's in part helping whether they're 2-year-old and masturbating by rubbing on Dolly, or whether they're 15-year-old and masturbating, or 40. Private place, appropriate time. This is your private time. Different people have different names for it, but making sure that, again, it's not necessarily a bad thing, but it's appropriate, safe, and in context of what's going on around them. Again, we want to make sure that we offer protection for our physically or cognitively impaired patients in terms of making sure that they're not the victim of unintended or coerced sex. And then I think in terms of seizure control, we know that progestin increases the seizure threshold, so can be preventive in terms of helping decrease number of seizures, and estrogen decreases it. So thinking that Depo, Implanon, those might be extra helpful methods for someone who may have seizures around the time of their period. So as your developmentally delayed or epilepsy patients start to hit puberty, maybe talking with mom, let's pay attention to how her seizures do around the time of her menses, so that it's not a big surprise. Oh, we just noticed this trend. No, we can be on top of them and perhaps offer them intervention early. And then what medications is she on in terms of interactions? What's the CDC guidelines and the WHO sort of scoop on interactions with contraception? Well, they really looked at the literature, and despite lots of anecdotal evidence, we really can't prove that there's a decrease in contraceptive efficacy with broad-spectrum antibiotics, antifungals, and the antiparasitics. We do know that with rifampicin and rifabutin, yes, there can be some decrease, where estrogen containing as well as the low-dose pills or the Implanon may be less effective. But in general, there's not too many medication interactions with many of our contraceptive technologies, and we'll talk about a couple of specific ones in a minute. One of the things that comes to mind is, as I go through all the medications and interactions with the WHO and the CDC, is the Depo-Provera is one of the methods of contraception that has some of the least interactions with almost any medicine, including many of the tricky ones like the antiretrovirals or the anti-epileptics. And again, the IUDs are a great method for that. So we know that combined oral contraceptives, we know that there's a specific interaction with lamotrigine. So if you're going to put a patient who's on a single agent lamotrigine, we can decrease their levels pretty significantly. So that might have to bump up, or we may need to think about a different method. We know that folks on AEDs, and especially in lamotrigine, may have an increased risk of seizures week 2 or 3 or at the end of the pill-free interval as the hormones change in relation to their daily medication of lamotrigine. And we know that COCs can also decrease valproate. AEDs or anti-epileptics can also affect combined oral contraception. And we can see increase in steroid metabolism as well as changes in protein binding. And so we know that phenytoin and carbamazepine decrease both estrogen and progestin, potentially making oral contraceptive pills less effective. Topiramate decreases the estrogen component, and lamotrigine decreases the progestin component. And lamotrigine has this funny, and I can't quite explain it, where if it's a single agent, it really can decrease the effectiveness as oral contraceptive pills and becomes a category 3 or less likely to use method for estrogen progestin containing methods. But then if it's with another method, it's not quite so detrimental on the effect of oral contraceptive pills. So it's a little bit, the properties of it seem to change when it's added on with other anti-epileptic drugs. This is another chart I have in clinic for folks who have either these medicines for seizures or for mood or for other reasons, in terms of knowing which AEDs decrease contraceptive efficacy by acting on the P450 system, and then which AEDs don't have P450 effects and so are much easier to use with something like an oral contraceptive or a combined estrogen-progestin method. And so I keep that chart in my clinic just so that as I'm looking through medication lists, I can align their family planning method with maybe their seizure control. So what to offer patients that may be on these medications that may impact their contraceptive efficacy? Well, some people would say we'll offer them a 50 microgram ethinyl estradiol dose. That doesn't really make sense in that the ethinyl estradiol is really just linked to lining of the uterus stability. And the dose that we would need to really be using the ethinyl estradiol to decrease ovulation or inhibit ovulation is more like 100 micrograms. So that even though it's anecdotally out there, doesn't make any sense. We can think about OCPs with progestins well above the ovulation inhibiting dose in case there's one of the medications decreases the progestin efficacy. We can think about continuous cycling to maybe avoid these hormone-free intervals. And then we can think about other methods like progestin only or long-acting reversible contraceptives. But I think we have to sort of think about our interactions, how the interactions truly act, and the mechanism of action of our contraceptives as we juggle when someone's on a certain other medical regimen, how does it interact with our contraceptive plan? And again, the WHO and the CDC medical eligibility websites are really wonderful resources for that. 17-year-old at your office for a pre-college physical, and the past medical history is notable for migraines. Factor V Leiden, the maternal grandmother, and she wants birth control just in case. She wants to be ready. You guys have had the great talk about not drinking at parties and wandering off with other people, having someone be the designated sort of person that keeps an eye on the pact if they're going out and socializing as a group. You've talked about, condoms, birth control in general. What do you want to do with her now? What more do you need to know, and what do you want to do?
What does she mean by migraines? A lot of people think migraines.
Yeah. Yeah. What is sort of a migraine, and where are the classifications for a true migraine or classic migraine or migraine with neurologic sort of sequelae? What about Factor V Leiden? Yep. So that's a prothrombotic condition that makes us very, very nervous about thinking about any other prothrombotic event like adding an estrogen. So the CDC medical eligibility and headaches, I think, is again really clear. There are musculoskeletal headaches, migraine and no aura in the younger population, and then migraine with aura. I think the easiest thing to really remember is if they have an aura, and that means the prodrome before the headache, the prodrome stops, or if you interrupt it, there's no headache, and then the headache. So aura or scintillating scotoma, or sort of neurovascular changes, numbness, weakness, loss of vision, one-sided. All that just means no estrogen. You just don't want to use estrogen on that patient. Which then gets you into the probable progestin or long-acting reversible methods. Again, with just general headache that we would call maybe more musculoskeletal tension headache versus a migraine, we can use anything. And the CDC gives you the CDC medical eligibility criteria gives you all the references where you can look at the science behind where they come up with these recommendations, and they review this every 4 years, which is just, again, so nice. So again, estrogen progestin methods, progestin only, which we can use in most circumstances or any circumstances, and then the IUD. So thrombophilia, family history usually doesn't improve detection. And people will ask me, well, should I test the patient for thrombophilia? What you really want to do is test the index case. So if you say, my mom had a blood clot, rather than do all your thrombophilia screening on the patient, you want to see what screening or testing was done on the mom. And that will give you an idea of what you might need to look for with your patient. Again, it increases the relative risk, but in terms of absolute risk, a family history typically remains, the real or absolute risk remains fairly low. Factor V Leiden disease can really significantly increase your risk for a clotting event up to 20 to 30 times. So that's something that would generally be considered, do not use estrogen with this patient for the most part. Other diseases, antiphospholipid antibodies. Again, another thing to think about in terms of patients with lupus or other autoimmune diseases. And then again, there's some other thrombophilias that are much less common, but again, in the background, something to think about or consider. So who do you screen for? Well, if you have a patient with a prior thromboembolic event, you absolutely want to test them. And then if you have a family history of a patient with someone who has a thromboembolic event in their young ages, not necessarily, 40s, 50s, 50s, 60s, because age is really one of the strongest predictors for a thromboembolic event. You might want to test the index case and say if your aunt, your sister could get tested, that would have value to you. And again, we have a variety of different initial and clotting tests that our fellow hematologists have suggested in terms of a beginning workup for the many, many factors that can be linked to risk for thrombosis. And the list is huge in terms of clinical risk factors that we can sort out by history, exam, as well as some of the laboratory-based factors that lead to potential increased risk for a thromboembolic event. And I think we just need to sort of keep that list in mind as we screen for patients depending on their clinical situation as they choose their contraception. And again, the big issues are going to be this sort of personal or strong family history, age, and tobacco. And again, that's not a big issue for most of our patients. Again, these are the specifics how oral estrogen, progestin, contraceptives work in terms of increasing the predisposition for a venous thromboembolic event in terms of activated protein C resistance, increasing procoagulant proteins, and decreasing anticoagulant factors. And what's very true and what you'll see is that if a patient has an undiagnosed thrombophilia, the real time that you're most likely to see it is in that first 6 months that they'll have a thromboembolic event. And then that risk is still there and increased at 12 months, but somewhat less. And then if you have someone who's been using many, many years of pills without a thromboembolic event, again, it's just less likely that they have that sort of background thrombophilia. And again, age and tobacco use, big factors in terms of a VTE risk. These are a couple interesting studies that I brought up because when we talk about aches, we talk about strokes and we talk about heart attacks. Really, in our population, the adolescent population, VTEs and pulmonary embolisms are the main events that we see. If you really look at the literature, thrombotic or hemorrhagic strokes are very, very rare and not really related to OCP use, and the same thing with heart attacks. So I think that's just easy to sort out. And one way we can just decrease this list of risks that we talk about and give to patients. Again, in older patients, that's very different. And again, what's the deal with the increased risk in third-generation progestins? We think it's maybe related to that activated protein C resistance, that some of the progestins may have more impact on that pro-thrombotic protein. So I think over time, right now, progestin is a method that we recommend for women who have histories of venous thrombotic events, strokes, etc. It's not 100% certain that these are as safe or absolutely risk-free as we once thought. I think we'll be finding out more over the years how exactly progestin interacts with the clotting system so that we can, again, better counsel patients for risk. So right now, the standard of care is still offering progestin-only methods for patients who have a history of or increased risk for a venous thrombotic event. But again, I think just the science is evolving, and we need to be aware of that as we counsel our patients and keep up with it over time. And I think, let's stop here because it sounds like we're done. Questions? I tried to sort of embed a number of different issues in the cases. I'm open to feedback. I tried to cover a lot of material, but I'm open to feedback as to the cases or things to add, cut, or keep out. So thanks for your attention.